Okay, so the topic that is assigned to me, I think all these are sponsored sessions. That means the MUA will also have some income from this session, and also we have a good time together. I think this topic is appropriate for us, BPH and all the LUTs associated with the prostate, associated prostate may not be due to the prostate and nocturia. I think this is a big chunk of our urological practice for most of us, maybe except for Vijay at the moment. I see Vijay, he's doing mostly transplants now, so maybe not so important for him right now, but I think it's a very important aspect of urological practice. So what is this thing called BPH? You know, for 30 years, we are saying BPH on all our records, you know. So it actually is a histological diagnosis. It is a histological diagnosis. So I think most of the well-trained urologists and well-trained doctors will no longer put BPH on the diagnosis. When we see a patient, there's no clinical diagnosis as BPH nowadays. Most of those who are well-trained, especially from UNIMAS, right? Dr. Vijay. Okay, so I was looking through what are the best slides to show you all, to share my experience view, and I found this picture of an old document that me and a few people, I think probably Peter also involved in this. They were the young Turks in those days, 1998, and I have not updated it. I have not updated it. You can accuse me of being lazy or whatever, but actually that's not the point. Now the MUA, we've got so many exciting things that, Dr. Rohan and Dr. Selva, we are doing the board of urology, we are doing training, we are doing transplants. So actually what MUA has done is that we signed an MOU with European Association of Urology, and they update it every year. So we have a linkage. So you want to look for guidelines for MUA, go to the European Association. And of course, here and there, I think each department may have its departmental head may have some guidelines now, okay? So what am I going to talk about? I'm going to talk about a very important topic. 50% of our workload, I think about 50% of most urologists, except you're working in specialized units like VJ, it is about this thing about urinary tract symptoms and BPH, and also nocturia. We often forget about nocturia. And also the concept in this field, the concept the public and most doctors is that I got BPH, so I must take a medicine to reduce the size. But is size that important? Is it so significant? And then we talk about investigations. You know, as urologists, most of us, we are surgeons. So we want to do things to the patient. So what are the things that we need to do? Actually, what is that we need to do to investigate the patient with BPH? Actually, there's not so much in terms of surgical procedure. You look at Professor Katie Fu's concept of the intraprostatic protrusion, the stage and the grade. He wrote a book recently, and he gave quite a lot of copies to Kuching. And then we talk about the various medications. And then, as usual, I like to share my cases and my preferred practice, which you may object, which you may disagree, and we can discuss it at Q&A. So just a quick revision about the prostate gland, because we have got almost 200 people, so not all of them are urologists. So for those who are non-urologists, the prostate gland is, to me, is actually a sexual organ at the base of the bladder. So the bladder and the prostate and the sphincter are important organs for urination and for ejaculation. And because the nerve through the penis go near the prostate gland, somewhere at the front and the back and the lateral side, they're also responsible for erection. And the bladder is responsible for storage and also for voiding. And we mustn't forget about the sphincter as well. So it's a quick revision. And of course, this is connected to the ureter and the kidneys and connected to the rest of the body. As Prof. Fu said, you mustn't consider an organ in isolation. You must consider the disease with the patient and with the community. So with that in mind, I also want to do a quick revision in case you think that we're just talking about one topic today. In fact, they're all connected. What causes lower urinary tract symptoms? So I mentioned the bladder, the prostate, and the bladder, we used to think it is okay. But actually, we also know that the bladder also undergoes aging. The bladder also have become underactive. The sphincter also have dyssynergia. Of course, we have infection and cancer, of which can cause similar symptoms. We have the sphincter. We have a lot of urethral strictures in Malaysia still. And also we have a lot of stone disease, and the stone may not be in the bladder. The stone in the lower ureter can cause symptoms. I have missed it. I have missed it in the nephrologist's father when I was in GHK. The nephrologist's father had a stone in the ureter, and we thought he had a BPH. And of course, this is connected to the rectum. In the female, is the cervix, and then the spine. And then all this is connected to the spinal cord, connected to the brain. and connected to the pituitary gland. So all this can give rise to, of course, sleep and higher order thinking lah. I think most of us have some higher order thinking. Most of us lah. Okay. So all this can cause LUTS. Okay, or LUTS. If you ask me, this is the most important slide. Okay, now we talk about BPH. How common is BPH? Microscopic BPH. If you biopsy men, I'm 64, so the chance of me having BPH is more than 60%. So I can talk from personal experience, not only my patients, of urinary symptoms related to BPH. And in your practice, depending on whichever origin you are from, I see 165 participants. If you are running a GP practice, I think the thing is there, but you're not asking about it, because most patients think that, oh, I have urinary symptoms, I got no blood, I got no pain. Maybe it's just part of aging, maybe part of aging. So I think we grossly undertreat LUTS. We grossly undertreat nocturia. Okay, what is the figures in Malaysia? We'll talk about figures overseas. This is the National Health and Morbidity Study conducted by the government. So they actually interview households. They go to household and interview, and they found that 16% of men has symptoms. They suffer from BPH. Okay, suffer from BPH. 16% is a community survey, but it does give you an idea what is the thing. Of course, as I said, I don't just look at this alone. I look at what are the other things they publish. And my God, diabetic 20% in Malaysia. But you go to some kampongs, I think it's 50%. When I was a medical student, we did some village health surveys, up to 50%. And then what about hypertension? 30%. The 30% is okay, but half of this 30% did not know that they have hypertension. And those who know they have hypertension, another half are not controlling their blood pressure. So we must put this all in context. Okay, now we talk about the prostate. I mentioned earlier that doctors, some urologists, not all urologists, and the public, they think that the prostate size is the most important. Okay, so the public said, I want something to shrink it. Urology said, I want to remove all of it. I must remove as much prostate adenoma as possible. Okay, but actually, the prostate can grow outwards. So you can have a 100-gram prostate, but patient pee very well. So I think that is a very important factor even today. Okay, now we'll talk about the symptoms and my topic, nocturia. Nocturia, by definition, is only one time, but you must try to go back to sleep. And actually, I was shocked that it's only one time. Professor Ong Teng Ed came to Kuching to help us run our Borneo Urology Update. We have a Borneo Urology Update in Kuching every year, headed by Dr. Teh Kwan Chow. And Prof. Ong emphasized that all of you in this room, I think almost all of you have nocturia, because it's only one time. It's only one time. So there is no QOL. There's no quality of life score when we talk about nocturia. Not yet. Maybe one of us will do some research. Actually, whether the nocturia affects your sleep or not, whether it affects your functioning the next day or not, whether it affects other things. People have a rumor. There's a rumor that if you have nocturia, you die earlier. So the quality of life is not well studied. The other important factor is the topic of polyurea. So how much urine you pass at night, the volume you pass at night, usually should be less than 1/3 now for most people. But I think for younger people, I think they move the definition a little bit. So even the definition of nocturia is a slightly changing target. Okay, but to me, most important thing is the quality of life, which is at the moment not well studied, not well documented, very few studies. So coming from Sarawak, we always quote this landmark paper by Dr. Teh Kwan Chow. Okay, 1998, we got 2,000 people coming to GHKL. I don't know, VJ, how many now? I think maybe still a lot of people. Every year we have this, the Malaysian Urological Association, this prostate awareness. Hundreds, if not thousands of people will come to our campaign. I think this year we didn't do it. We canceled it this year. So nocturia is prevalent in I think in almost all the studies, not only in Malaysia. We did a study in ASEAN. Actually, they put Asian, but actually it's mostly ASEAN. Okay, and I think quite a lot of us. I think many of us in the audience are participated because there are 26 centers. So we collected data, and again, nocturia is 64%, and this is published quite long ago. VJUI no, I mean the BJUI 2007. Even at that time, medication in Asia is the #1 treatment for prostate. #1 treatment. So most patients can be treated. So for the 174 people in the audience, you can treat BPH. You don't have to ask a urologist to treat BPH. Of course, we like to think that we are the leaders. No, we'll give you ideas how to treat BPH. So that is nocturia. And then what about so many other symptoms? Storage symptoms, voiding symptoms. And the most important symptom eventually is urinary retention. Urinary retention. Okay, this patient, I always show this slide when I give a lecture. This patient had many procedures done already. He had circumcision done, phimosis. He had scope done. Okay, then he had PRP done. And mind you, these are done in the top hospitals in Kuala Lumpur. This site was taken when I was in Kuala Lumpur. And he still got retention. And so his retention is nothing to do with urology. Okay, what he has is, you can see here, he had diabetic neuropathy. Okay, diabetic neuropathy. So we must never treat patient in isolation. This is another patient. He's 74 years old, plumber. You know, they always say that urologists are just high-class plumbers, you know, but actually plumbers can earn more than some of the younger urologists. Okay, they earn more and have a better lifestyle. Okay, so he had nocturia for 6 months. These are real-life cases. I'm sharing some real-life cases. As I said, I may have managed them not to the way you manage them, and we can discuss in the Q&A. He went to see his GP, the GP in that town, not in Sarawak. And of course, you know, depends on who you see. You see a GP, he will give you LASIK. If you see a cardiologist, he do a Doppler. You see an orthopedic surgeon, he do an X-ray of your ankle. Well, I'm just being sarcastic, okay? But that is sometimes the way we think. So he went to the government clinic. This government clinic, now the government are very good. One Malaysia, UTC. The doctors are very well qualified. They have got family physician. So what did the doctor give? They give prazosin. Again, no better. Give prazosin 1 milligram BD. So he came back to his family doctor. No? This idea of family doctor, somehow the Malaysian public somehow still don't buy it. See, the family doctor look at him and say, okay, you got generalized edema. We better run a blood profile on you. And my God, the blood profile was, the PSA was 466. Okay, we know that. We say we don't simply do PSA anyhow, but also don't underdo PSA. And alkaline phosphatase is 509. Okay, all the urologists in the audience will know that means it's not the liver, it is the bone. Okay, prostate cancer go to the bone. So he had the prostate. I did prostate biopsies for him, and he already done the CT scan in the periphery blood town. He doesn't have to come because now we got telemedicine, you know. So the radiologist in another town can do, and he got hydronephrosis, and of course we know that the prognosis is usually not so good, but of course he suffered for months because people thought his nocturia is due to whatever. Another patient I see. So we just talk about differential diagnosis of LUTS, which we often miss. This patient, I saw in the periphery town, 2016, and he has difficulty passing urine, frequency, whatever, you know. And now we train the doctor to say, you must do uroflow, document the flow rate. And he got 10 uroflows done over 5 years on dual therapy. Okay, no improving. Better go and see the old doctor. So actually he had a urethral stricture, and he had no evidence of trauma. But a lot of patients now, they go for orthopedic surgery. They just go and see an orthopedic doctor and they have surgery done. And of course, orthopedic doctors are very busy. So usually somebody else will put the catheter. And he told me that actually after the surgery, the most pain he had was from the urethra, from the penis, not the operative side. So he had a urethral stricture. So we must bear all this in mind. Okay, so that's differential diagnosis. The next thing is examination. Do we need to examine our patients? They always say that urology patients not much to see, you know. Okay, no, you can't feel very much. So you must examine the patient. So look for phimosis, okay, and look for distended bladder, which I showed earlier. And usually we do a rectal examination. If we are the last station, we do a rectal examination. If we are the first station, you have got 50 patients outside, you can't do a rectal examination. But you must send the patient to another doctor, SOPD guy, urology clinic, to do a rectal examination to look for any hardness, cragginess, not so much to assess the exact size of the prostate, but you know, to feel any prostate cancer, not cancer. And of course, we always do a urine test. I think that every patient who has LUTS must have a urine test. And you can just do a dipstick, put it in the machine, and you produce the results. Check the blood pressure, check the blood sugar, check the pulse rate, check the body weight, minimum data. And I think most of the urologists in the world, most of the urologists, unless they work in a very specialized unit, the ultrasound is actually an extension of your physical examination. And in particular, we look at IPP. Now we are next to Singapore. We're next to Professor Ketifu. So he had this idea that IPP is extremely important. Okay, extremely important. So IPP indicates more likely to have a urodynamic obstruction and symptoms which may not be amenable to medical therapy. And I think in Malaysia, most patients would have done a PSA on the lab, because the laboratories in Malaysia are still not controlled by the pathology bill for some reason. I think 1.5 is a bit high, maybe 1.4 lah, 1.4. Okay, so this, to me, this is the basic examination. The next specialized examination, which unfortunately in Malaysia is not widely available, is the uroflow. To me, I consider the uroflow a must in urology. There are a few urologists who strongly disagree with me, but I think it's a must, because you look at the uroflow is normal, uroflow is diminished, and this is the low uroflow, this is the uroflow after treatment. In fact, this one is just after defecation, after defecation. So I think uroflow is a must. If I have a choice, I'll make uroflow free access like ECG to the public. Okay, next we move on to treatment. Okay, because we only have about 45 minutes. We leave 15 minutes at the end for discussion. So I think this is what I call a no-brainer lah. People know that you got prostate problems, you take a medicine to shrink the prostate gland, reduce the size of the prostate gland. This is what the patient want, and this is what a lot of people want. But we know that this takes time to work, so we give them another medication to relax the prostate gland. Okay, to relax the prostate gland, so that you can pass urine better. So this is actually no-brainer. Okay, so this is an easy one. So this is the medication, relax the prostate gland. Okay, but what a lot of people don't realize, even medical people, of course urologists we know, it takes up to 6 months to show an effect. 6 months. So who is going to take a medicine for 6 months if there's near retention or you got severe symptoms? Okay, 6 months. And recently we have more problems with this medication. I got a patient who called me, the daughter actually is the daughter from Australia, like usually from South Africans, they're like twin city with Adelaide. Say, doctor, you are giving me a medication to my father. It says very clearly in the product insert that my father will get cancer for this, and not only cancer, high-grade cancer. Okay, so there's one problem. You must be ready. We can discuss at Q&A. And the other problem is that I got some usually Caucasian patients lah. He will say, my doctor gave me this. I take only one tablet. I'm impotent. And I check the internet. Yes, there are hundreds of people in the US. They in fact form a club to say that this medication gives them permanent, irreversible impotence. And then, doctor, you didn't tell me it's inside the leaflet. So these are the problems I have. We can discuss later on whether it's true or not. So if you compare both the mechanism of action, the 5-alpha RI inhibitors, like finasteride or dutasteride, they shrink the prostate but takes time to work. So you want fast relief, you give them an alpha blocker, right? Alpha blocker will give relief, I would say hours to days, not hours to days. And the rest are basically the same. So if you are a busy doctor, physician, cardiologist, consultant cardiologist, interventional cardiologist, and then they have a lot of patients, we share the patients, same age group. They will just give them a combination therapy. Just give them. Everybody come above 60, give them combination therapy. So there's a problem. Of course, there's a cost problem and the side effect problem. So as a urologist, I think recently we had a discussion in Kuching. I think we have to re-educate the public regarding this aspect of therapy. So these are all the medicines that you have. Mini press. Okay, I have a story to tell you about mini press. Okay, mini press. Klinik kesihatan, I think this is terajosin, avodat, hanal, duodat, urif. This is the urif from Indonesia. Malaysia got a lot of, last time we had a lot of medical tourism. So Indonesians have a slightly different, I think the same formulation but different type of packaging, and somehow some of the medication are cheaper. Zatral, Hytrin, terajosin, duodat. This is the Rixac, the combination therapy. Just give it. And then don't forget the herbals. There are lots of herbals which can be used. And usually I'm a bit benign about. I'm very kind when people talk about herbals. Last time I used to be a bit aggressive, but now I'm a bit kind when talk about herbals, because usually it's bought by somebody. Somebody is a family member, so that is itself is therapeutic. So now I talk about the different alpha blockers. When I started doing surgery, 1984, we use prazosin. We actually have a starter package for prazosin. So I also feel okay about prazosin. Although I know there's one urologist who resigned from the government service because he said, hey, our Ministry of Health is terrible. How can they be giving prazosin to the patient? You know, we are living in the Stone Age, blah, blah, blah. But actually, I think if you really think of it realistically speaking, in terms of cost, it's just that you need to titrate. You need to titrate the dosage. Then we have the sort of non-NOx selective. Oh, there's a beautiful girl there. So NOx selective alpha blockers. The problem is that they are also used for hypertension. Well, they were used for hypertension. We don't use them anymore nowadays because we know that they cause leg edema. So most of the cardiologists, physicians don't use an alpha blocker to control hypertension. But if you use it, you have to titrate it. You really have to titrate it because it can really cause significant hypotension because these drugs are actually used for hypertension. And I also got patients who check the internet. I think most patients will check the internet. Oh, this one doctor give me medicine for hypertension. Salah, give me the wrong medicine, you know. So you have to tell them that this drug works also to relax the prostate gland. Then we got the more uroselective like alpha-josin, tamsulosin. And now, of course, we got silodosin. They sponsor this session, so I have to talk about silodosin. I have no choice, can. So silodosin, but actually, it's actually cheaper. I heard lah. I'm not sure. I think maybe this is significantly cheaper, but still very much more expensive compared to the generic medication. So we actually cannot compare the generic medication lah. So now I have to talk about the medication. Now, why did they choose me to talk about medication? Because I work in a state-owned hospital where I got a lot of corporate clients. I have a lot of corporate clientele. So when there's a new drug, I can use them on my patients if I think it's appropriate lah. So I asked my pharmacist last week, and so she did up the last 18 months. I had 134 patients. It means individual patients, not repeat patients. So I do have some experience with this medication, but I have no time to analyze them. I can only give you the demographic figure. I can't dig out the figures and do a prospective study or whatever, because I think people have done it already. It doesn't make sense for me to do prospective studies, but I can tell you real life experience. I use it only in 2 females. So I'm thinking, my God, what happened? And I look, actually, they have got lower uteric stone. These two are young females with lower uteric stone. So I haven't used it in female for dysfunctional voiding. Have not used it. I don't know. And I actually use it for quite a long time. You know, those who are with me, I use it for 8 months, median 8 months, because they're corporate clients. Of course, in Malaysia, people buy the medication on their own. Earlier on, there was a question of intermittent therapy. So it's the patient-led intermittent therapy. Okay, they buy the medicine, and the pharmacist, not guided, pharmacist sold intermittent therapy. Okay, so there's the real life, my real life experience. Okay, what else? And I look at the age group. I calculated last night only. Quite a lot of my patients, 30-over patients are above 80. So these are the patients that probably have a hypotension. And I also use, you know, this silodosin is supposed to be 12 hourly. I use it at night only, 1 hour, Nocturia. I haven't used it in children, although I've used it in below 40. But when I look through the data of my patients below 40, I think some of them are stones, low uteric stones, and some of them are dysfunctional voiding. Like they've tried everything already, you know. So I said, okay, maybe you just try this new drug. No, they got this new drug effect on them. So these are my patients who are on it right now. This is my real life experience. So most of the patients who are with me now, they are mostly new patients with either BPO or BPEO. E means enlargement. That means I have add one more drug. And as I said, my ultrasound is an extension of my examination. So I more or less have a size of all my patients. Measured size, measures not rectal size, but the ultrasound size, either transrectal or abdominal ultrasound. Or some of them are not happy with the flow when they are already taking some tamsulosin. Somehow my practice right now is, no, I'm not citing any company. Most of my patients were on tamsulosin. So I'm not happy. I tried this silodosin. Or some of them have got side effects. The two prominent side effects is postural hypotension, nasal stuffiness, or dizziness. Sometimes they actually don't have postural hypertension. They just feel dizzy, dizzy. And new patients, I give them for lower uteric stones. And there are not many patients because I don't believe that alpha blocker works for upper uteric stone. I don't think you need it for small 3 or 4 millimeter lower uteric stone. Okay, so I don't have that many patients. If the stone is above 6, then maybe you should remove it by surgery. So I don't have that many patients who are on alpha blocker. And I feel dyssynergic voiders, dysynergic voiders. I think Susan got more experience with this group, and I think most of our previous work is probably on terazosin, I think. So I tend to use terazosin in the pediatric age group who have dysynergia. So now we talk about this drug. Next few slides is about, well, the next 10 slides probably on this drug. What this industry sponsor talk is about, okay? I have no choice today. So this is a highly uroselective drug. Highly uroselective drug. Okay? They got alpha 1A, 1B, 1C, 1D. Don't ask me that, okay? I'm not a pharmacologist, okay? These are all postulates by the drug company, but it is supposed to be highly uroselective. Okay, I think you ask a pharmacologist, they also cannot tell you about this alpha 1, 2, 3 receptors. And it works within 2 to 6 hours. 2 to 6 hours. That means it works very fast, very fast. So if one of you, if any of you in the audience, or you have a patient who have difficulty passing urine, the patient and the doctor said, oh, you drink more water. Actually, you drink more water, you go into retention faster. So if you have got bad near retention, stop drinking. Take the medication. If the house is nearby, go home. Go home, empty your bowels, have a shower. And then if you still haven't passed urine by 3:30 or 4 o'clock, then you can come back to us for the catheter. And I tell you, it often works. It often works. It often works. And from these are the earlier studies. The effect starts 2 hours, 2 to 6 hours, and it may from this particular study is maintained for 12 weeks. These are the studies they have done before they register the medication. Okay, what about another criticism of alpha blockers? Not alpha blockers, they say it's like Panadol, you take Panadol, no more headache. Of course, you don't have to take the Panadol forever, So the same thing, I say the same idea to the alpha blockers. They say, hey, doctor, I take this medicine forever. I said, if you think you can pass urine well, you can stop it, But this particular study shows that actually there is a urodynamic improvement proven urodynamic improvement with alpha blocker. In other words, if you have this thing called high pressure chronic retention, hydronephrosis, renal impairment, we always say this is one of the cases where the patient will require surgical therapy. But in case the patient is unwilling for whatever reason, he got 3 young wives, or he has got he's on warfarin, or he got a history of deep vein thrombosis every time he goes to theater or whatever, if for some reason he is high risk for or not willing for surgery, I think alpha blocker therapy can be used in these patients, or at least in the meantime while waiting for surgery. So this, to me, I think it does change the course of the disease. And then what about this? Patients who are retention. In Malaysia, it's quite common, I think, especially in Sarawak. Patients will not see a doctor or cannot see a doctor don't talk to them until they are in retention. So they go to the emergency at 11 p.m. The doctor put a catheter. Oh, painful, but anyway, the pain was in the suprapubic. Now the pain is in the penis. Okay, patient, you go away. You go to the nearest clinic. Go and change your catheter every 2 weeks. So that the doctor write a letter, chop. No? Now we know who chopped it and where they graduate from also. Please change catheter every 2 weekly. And to my surprise, I tell you, I've seen so many patients over the last years. Patients just have to change the catheter every 2 weeks in the government clinic or in the private clinic, because the doctor written there, hospital, the hospital job is gospel truth. So I think you have to give them medication and also work towards the trial of catheter, and usually try medication. If you cannot, of course, eventually they should be listed for surgery. Like they cannot be having catheter for years and years. This reflects a very poor quality of care in well, how should I say, in the country lah. Okay, so a trial of catheter. We know we have done these studies earlier with aflatoxin. I've done it in Edinburgh when I was there. So silodosin also have a very good success rate, 76%, but not perfect. Okay, so don't ask patient come at 4 o'clock for trial of catheter. Okay, any nurses in listening audience, always come in the morning, 8 o'clock. Better still, ask them to remove the catheter themselves. Self-talk. Remove at home at 8 o'clock, or remove at home at 6 o'clock. Most people in Malaysia, many people in Malaysia wake up at 6:30, to exercise, and then remove the catheter and see. So trial of catheter it shows that this drug is effective. Okay, now the most important thing. All these alpha blockers, no matter how uroselective, they can cause hypotension. Okay, hypotension, and it's about 2%, about 2%. The older you are, the higher, higher. So you have to warn. You must tell every patient. And I tell you from experience. I had a patient. He took the medication. Then he went to shopping center lah, because want to tengok perempuan jalan-jalan. After makan, you still take a night lah, take at 7 o'clock. So he fell down. He lacerated the scalp, get admitted to CT brain. Usually once you go to emergency, the neurosurgeon on call to CT brain. So you have to tell them that this can cause hypotension. Please stay at home after taking the medication and don't stand up suddenly. And if you feel giddy, check the blood pressure, because it may not be postal hypertension, maybe just one of the sort of dizziness side effect. So you have to tell them. Now, whenever there's a new product in the market and the patient has got comorbidities, I've got 2 patients like this. The physician removed the silodosin. Say, Clarence, I think this medicine somehow he thinks he imagines it affects the thing. So if you talk to the physician, you must arm yourself as a urologist that, okay, show me the evidence. Okay, the evidence is the QTC interval. Okay, this is where some of drugs seems to affect the QTC interval. So if the patient is known or there's a family history of QTC interval problems, then this is one of the relative contraindication for this medication. Okay, so not every patient. I think these patients are very few and far in between lah. Okay, and then we talk about, I think some of you who have used this medication, I think the government is still not the Ministry of not available, but you may have used samples. The most well-known side effect is so-called retrograde ejaculation. Okay, retrograde ejaculation. But like many new drugs, that side effect is actually indication of the efficacy. So if you have no ejaculatory dysfunction, okay, they use the term ejaculatory dysfunction, not retrograde ejaculation, it is not so effective. Okay, so the fact that you have retrograde ejaculation, that means the drug is more effective. But as Dr. Tay Kwan Chow reminded us, it is not contraception, okay? It is not contraception. You cannot use it for contraception. Not effective, because there is still ejaculation, just less volume of ejaculation. So you look at this chart, okay? High percentage. This particular study, 20%, 1/5 patients has retrograde ejaculation. The rest of it are all in small numbers, 1%, 2%. But the hypotension is important. Because nasal congestion, quite common among our patients. So all the alpha blockers. So they can't sleep at night, because when they ask them to take it at night and they lie down and they cannot sleep because the nose is blocked. Okay, so nasal congestion is, to me, these are the significant side effects. Dizziness, postural hypotension, nasal stuffiness. I think for all the alpha blockers, but in particular, retrograde ejaculation is seen in this particular product. So as urologists, we need to talk a bit more about this thing now, because if we're going to use the product. So, but how significant, how important is it for us to ejaculate? How important is it that you ejaculate? Not ejaculate good volumes. How important is it? So actually about 2%, 2% of patients stop it because of this retrograde ejaculation, so-called retrograde ejaculation problem. I think we don't have a survey. Maybe one of the young doctors can do a survey. How many men above 80 still ejaculate regularly, and the volume of ejaculate is important? Because don't forget, this, I just go backwards since I have some time. This retrograde ejaculation thing, mana dia? This ejaculation thing is that the patients still have orgasm. They still have orgasm. Orgasm is a separate event. Okay, you can just look at a girl, you can have orgasm. You don't have to ejaculate. So orgasm is a different thing. So how many men above 80 place importance on the volume of ejaculate? Not so many. I think not so many. That's why only 2% of patients will stop taking the medication because they feel that the volume of ejaculate is less. And for long-term extension studies, due to all the side effects, small side effects put together, 9.4% stop the medication. So patients do stop medication because of side effects. We know that when we talk about anticholinergics or antimuscarinics, 70% of patients stop the medication. So every month, the Kementerian Kesihatan, every month they send by post laju to the house, but actually the patient is not taking the medication. Okay, so that is important. So these are the numbers. These are the definite numbers, but they're serious numbers, okay? 0.2, 0.5, 3.9. These patients stop the medication because of the side effects. Then, of course, we have to think of other options. Ada banyak options sekarang kan. Even the patient can ask you, tell you about the options. Okay, patients who are above the age of 60, including myself, so we have quite a high concern about erectile function. Erectile function. We don't say impotence we don't say impotence. So erectile function. We want to improve our erection. Okay, and so we also take these medicines usually at night. Not many people, well, most people are like us. So we are listening to webinar. Though there's some webinars we have this at night nowadays. So sexual function is important. So if you take the two medication together, you take dutasteride, take an alpha blocker, you take a PDE5. So will the pressure crash or not? Okay, will pressure crash or not? Actually, there is minimal. There is minimal change in the blood pressure. Although in the earlier days when sildenafil was Viagra was introduced, we say we separate it by 2 hours. We separate the taking of the medication by 2 hours. But generally speaking, if the patient asks me, I think it doesn't make so much difference since the effect, the synergistic effect on the blood pressure is not that great. Not that great. But of course, you are taking nitrates, a different story. Nitrates. So you cannot take PDE5 inhibitor with a nitrate. Still cannot. You still cannot now. Now you still cannot. Okay, let's talk a bit more about in fact, this was a slide I was looking for, the idea of ejaculation. As urologists, we spend a lot of time doing all kinds of other things, but we don't spend enough time analyzing this ejaculation concern. Okay, patients are concerned about it. So the side effect of this actually is not the retrograde ejaculation. There is less ejaculation of the fluid because of the relaxation of the muscles of the prostate, of the seminal vesicles, of the ejaculatory duct. Okay, so it's not actually a reduced, not a true retrograde ejaculation, but reduced seminal expulsion. Seminal expulsion. Of course, the person who produced this slide says is not a serious side effect. Okay, as you know, this is an industry sponsor. Some of the slides are from the industry. Of course, I go through them and I'm responsible for them. I'm responsible. Anything wrong with the slide is my responsibility. And luckily enough, this is reversible on discontinuation. Okay, I can tell you from my experience. Okay, it's reversible. Unlike the rumor about the dutasteride and finasteride, where you got impotence and it is reported that it's irreversible. So this is the thing, and this is an important issue because 20% of patients will have reduced ejaculation with this medication. So yeah, you also have to tell the patient. Otherwise, they'll call you at 10:30 at night. And nowadays, we all got this WhatsApp thing. They'll call at 10:30. Okay, now we go through a few studies. The first study is reported by our good friend, the Christopher Chappell, the Secretary General. I think he's still Secretary General of EAU. And I think he does most of these studies, all these functional studies. And they actually show that it is as good. It's a non-inferiority study with let's just put it bigger. Okay, so they show that the change for baseline for IPSS score is silodosin, and which we are going to use, and tamsulosin, which we have been using for a long time. They are as good. They are as good. Then another study shows that it also reduces not only the IPSS score, but also it significantly reduces nocturia. Okay, nocturia. This is published in the World Journal of Urology. World Journal of Urology. So this is in the Caucasian country. So we often don't refer much to Korean studies, Chinese studies, and Japanese studies, but actually they are more relevant to us. And we are beginning to see, with the UAA, we're beginning to see more of these studies, and they do good studies. So this is a Korean study, and it shows that it has effect on nocturia. And now we know that nocturia, actually, you look at the first two studies, the landmark study by Dr. Tay, nocturia is the most significant one. They are most significant. So silodosin is found to be safe, effective in the treatment of nocturia in BPH. So that is a very significant finding. Because the patient comes and see you, doctor, I got nocturia. But we know that as a urologist, we send him for the flow rate is poor. And we go through all the symptoms, we know that the underlying cause is probably from the BPH, probably from BPH. Okay, so this is another study, and they found that they reported, I show you more studies that actually it significantly it significantly reduces nocturia. Okay, at least one episode. Why this question about one episode? Why can't you cure nocturia? Okay, I tell you, it is not possible to cure nocturia. In fact, it's undesirable to cure nocturia. Imagine the patient don't pass urine the whole night through. So, but if you can reduce nocturia, increase the duration, the time he first wakes up. So he sleeps at 8 o'clock, he wakes up at 12 o'clock. He will feel much better. He have a better sleep. Okay, so that's the idea about reducing nocturia, not to abolish nocturia. I think it's too ambitious and probably not desirable and unrealistic for the patient not to empty the bladder at night. So if you reduce nocturia by once or twice and increase the duration from the first void, it improves the life of the patient significantly. Okay, that's published elsewhere. It's not in this study, elsewhere. And then the other big problem about this silodosin is that it is 4 milligram twice daily. 4 milligram twice daily. Okay, 4 milligram twice daily. So that can be a problem because people go to work. People go to work. And that reminds me that actually originally when some of the alpha blockers came out, like for example, I think it's tamsulosin. Yeah, tamsulosin when first came out, they got alpha-josin. They got 2.5. They got 5. Okay, so actually a lower dosage. I tried to look for the lower dosage, and the company said they don't produce it anymore. So I think a lower dosage, I routinely use it for patients who are above the age of 80, patients who have slightly lower blood pressure, like systolic of 90 or 100, and also patients who have significant hypotension from alpha blocker. And of course, as a urologist, we often offer them surgery, but sometimes patients do not want surgery for whatever reason. So this night dose, single dose night dose, is suitable for these patients. Whereas for the newer formulation like doxazosin, what they call XR, XL, SR, all these medications, actually you cannot cut it. You cannot cut it. Some patients say, oh, I will take tamsulosin, I cut into 2 so that I have less postural hypertension, but that actually destroys the delivery of the medication in the GI tract. So this actually allows you to not only use a lower dosage in suitable patients, but this particular study has also found that you can actually use 4 milligrams. 4 milligrams, because maybe we are smaller size or whatever, but this particular proof that, and I have here anecdotal reports from my fellow urologists that actually they use 4 milligrams, the patient is just as happy. And then what about patients who have already used an alpha blocker? They have used one drug in the same group, like PDE5 inhibitor or whatever, And this is a study done in Japan. This is called the SPLASH study, SPLASH study, Japanese study. And I found that if you have this post-marketing, okay, post-marketing means real life. Whereas the studies they are done, actually they are controlled. They remove all the bad patients, all the heart problems, all the whatever. So these are real life studies. Post-marketing is real life studies. They find that patients who switch from one alpha blocker to silodosin, it is effective. So you can try that if you like. You can try that if you like. Of course, there's the duration, no? You don't try it forever like that. I want to try for 6-7 years. If it doesn't work, then you have to consider other treatment choices lah. So my one of my summary slides now coming to the end. Okay, so I think you cannot write away generics. Okay, so cost is the issue. So if the medication is only 20 cents and another medication is 4 ringgit, and the end point is the same, so of course you have to consider that. You can also, I resign from the government. No, this is the newest drug. They must use the newest drug. No, I think we have to be logical when it comes to, because medicine is getting more and more expensive. There's what Prof. Ong said. There's what financial toxicity. You have to sell the house and you go bankrupt. I know the DG objected to the statement. You go to a hospital, remove the appendix, you use the credit card, 15,000, then you can sue for bankruptcy. So of course we try to use the Uroselective one, and in my practice, I think if it is possible, you use the best medication, use the Uroselective medication, and if it works, then you can down titrate. You can down titrate the medication to something that the patient can afford, or something available free of charge. Free of charge. We get free medication in the Ministry of Health. Which country gives everybody free medication? Okay, so get free medication. This question of blood pressure, I think last time we used to promote it, no, say, or alpha blocker, no, dual function. But I generally speaking, I find a lot of patients taking alpha blocker after 6-7 months, they got leg swelling. They got leg swelling. So alpha blockers are usually not used by the cardiologists, but I think the nephrologists and the gynecologists, they use it, for pregnancy, hypertension, and for hard to treat hypertension. No, people 3 or 4 medications, then they use it. So usually we don't use these medications for treatment. So I think I want to say a little bit more about nocturia. Okay, so nocturia is multifactorial. Okay, so don't go away with the idea that you give the patient silodosin, the nocturia will go away. Okay, there are so many factors. Okay, so we have another lecture, another day. In fact, I told Dr. Vijay that I will give another lecture on the nocturia, but next year, 2021. So psychology very important. Polydipsia. These patients, they must drink. They put a big bottle of water next to the bed. They must drink. Okay, we discussed that another day why they must do that. And then of course the detrusor muscle. This one you can add on beta-3 adrenergic, or you can give antimuscarinic. Heart disease, they must go for treatment if it is possible. Okay, I realized that some heart failure cannot be treated. Okay, they just die, finish. Bladder capacity, if you give them antimuscarinic, you can increase the bladder capacity. Diabetes insipidus, okay, so diabetes, a lot of patients in Malaysia, in the morning, 2 or 3 days before they see the doctor, they do a lot of dietary control. They go and see the doctor, the blood sugar is 6. Doctor, my blood sugar is very good. I said, why don't you check your blood sugar at night? You have to have a nice makan, take a few beers. You take the blood sugar at night at 11 p.m. Okay, your blood sugar is 20. Don't come and see me. You just go and see your GP and control your diabetes. Your nocturia is due to the glycosuria. Okay, estrogen deficiency. That one I'm not sure. I'm not sure what that is. You have to see the gynecologist. And of course, the prostate. We are very good in treating the prostate, but prostate is only one of them. And this important idea of nocturnal polyurea. That means the patient actually measures the urine. They must measure it. And it's more than 1/3. More than 1/3. So the patient will say, oh, at nighttime I produce 1.5 liters of urine. That means there is a window of opportunity to give them desmopressin. Okay? Or the trade name is called Minerin. Okay? Minerin. So just throw them a type of Minerin, they stop urine production at night. Good sleep. But unfortunately, it's not so simple. Okay? Not so simple. Okay, so the main problem is that this desmopressin, it will cause fluid retention. So if you drink at the same time, you're going to have serious neurological problem. So the instruction, this is the drug insert. I copied from a drug insert so that we don't have to beat around the bush. Okay, this is from the drug insert of Minerin. You must not take fluid for 8 hours. That means 2 hours before and maybe another 6 hours after that. Don't take. You must have fluid restriction. Must be enforced. Okay. Sometimes if you cannot enforce it, don't take the medication. Don't give them the medication. These are the compulsive drinkers at night. Okay. Don't give them this medication. And you have to increase the dosage slowly. And it says should not be initiated in the elderly. My God, I'm 64, Vijay, 64. So next year I cannot take this medication already. Okay. Cannot be taken for some reason. I don't know what reason. I think it's because the trials are usually because the trials are done on people who are under the age of 65, so they don't dare to say it's, well, maybe FDA or somebody say, how can you generalize to everybody, you know? So I think that's probably the reason. So you take the sodium before, take the sodium 3 days, take the sodium 7 days, take the sodium 30 days. And if the sodium is low, you have to stop immediately. But don't replace the sodium immediately because they will cause another disequilibrium. And I've seen patients in Sarawak, they get paralyzed. They call it CPM, okay, central pontine myelitis, and that is permanent. The patient cannot walk forever. Okay, so you have to be very careful when you use this medication. But of course, we have a lot of Minerin in the Ministry of Health, a lot of Minerin in Malaysia because we use it for nocturnal. What is this? In children with enuresis. But that is a high dosage, completely different dosage. Probably different formulation. So now they have a sublingual formulation for this purpose. Okay, so I'm coming to my last few slides now. I see Dr. To putting up his video already. Okay, so the other important thing is exercise. Okay, during this COVID pandemic, we talk about exercise, but this study has been done long ago, again done in Korea, and it shows that exercise, and they did huge figure, mind you, 69,000 people. Exercise has an effect on LUTs. Then just the last two slides. Okay, so lifestyle and bladder care. Obviously, lifestyle is very important. Obviously, looking after the bladder is important, like skin care, you know, skin care. This is my daughter helped me prepare this slide when she came back from holidays. Because in UK, you don't have that many toilets in UK, you know, so it's very important to preach toilet care to the patient. So you have to reduce the drink, but you mustn't be dehydrated. You drink when there is toilets available, you know. And then I think in KL, a lot of people put plastic bag of urinal in the car in KL because of the traffic jam. And take the medication. I think that you can take medication PRN. I think for most of these medications, you can take PRN. Unlike earlier on they say about this for prostate cancer, different kind. And then no sugar. I think Malaysia should have no sugar, or they should put a sugar tax in Malaysia because we have so much diabetes and take less salt. Somehow Malaysia we eat a lot of salt, especially in Kuching, a lot of salt. And then for the young doctors in the audience, who are the patients you need to refer? Who do you admit? Previously, 30 years ago, we admit everybody. Then, of course, the ward become congested. So actually, you don't have to admit them. Patients who have complications, stones, infection. And contrary to traditional thinking, only 1% of patients actually have obstructive uropathy. 1%. We tell them, no, you don't take this medicine. You got retention. You got back pressure. Your kidney will fail. You got kidney failure. But actually, it's only 1%. 1%. And let's be realistic. Let's be realistic. Let's be honest. 1/3 of patients can actually improve without their medication because they are doing other things. You know, they're exercising, you know, they're having pelvic floor exercise, they go to, you know, don't know what, some other alternative therapy, and many of them are stable. But we must pick up those who progress. And finally, I think this is probably my last slide. I stick out my neck and say, TRP is the gold standard. Okay? But it gives you real retrograde ejaculation. In other words, you actually, the sperm, the semen actually go into the bladder. And if you have a young wife or young girlfriend, you can recover the sperm after ejaculation and put into a container, spin it down, and then send it to Peter Ng, and he can do some IVF or something. Okay, so this is before and this is after. So TRP is extremely effective, but of course you must remove enough tissue, okay. So finally, this is my last slide, conclusion slide. So patients with lux due to BPH, you can give them alpha blocker. You can put it together at the same time. If the finance is right and you think the prostate is enlarged, then you can de-escalate antibiotic. Okay, and then if the patient has got very low blood pressure, heart problems, maybe you can just give them alpha reductase inhibitor to shrink the prostate, but tell them takes time to work. And when it works, if the patient has alpha blocker, you can also stop the alpha blocker. If there are borderline symptoms, my favorite drug now for overactive bladder is a beta adrenergic agonist. It doesn't have cognitive problems. It doesn't, well, it can still cause retention, but not so much. So what would you do? What would you do? Okay, what do you think about it? And this is basically my summary slide. I think I've been hammering from the beginning that we have to look at the patient as a whole, not only just the medication. And I went with my daughter when she qualified to New Zealand for holiday, and I saw this flow, and I said, I wish my urine flow is like this. Okay, thank you.
Thank you very much, Clarence, for that wonderful presentation, which was enlightening as well as very practical. All the practical gems of years of experience has been given. So we'll open this to some questions. I've got 1 or 2 questions in the chat as well as the Q&A thing icon. So I'll probably repeat that to you, Clarence, first. Let me read. This is from Benjamin Chui. Mr. Clarence, thank you very much for your insightful talk from your personal experience. Would you recommend silodosin over older medications, Cardura, Hana, etc.? And how are the reported feedbacks from your patients? You can answer this live.
I thought I already answered. Where is the question? I cannot see on my thing. I thought I have answered that already. The short answer is yes, but of course you have to look at your availability, your cost, and whether the patient is already taking the medicine. Usually patients who are happy with medication, I don't change it. I think okay. I've answered that already, Peter. I think it's
yeah. All right. Okay. One of the questions I wanted to probably bring to you, since there are no other questions yet, you know, silodosin is supposed to be so much more uroselective compared to tamsulosin and all the rest, and the specificity, 160 times more. Do we have any evidence that is Qmax wise and all that is going to be significantly better than tamsulosin or alfuzosin and all the rest? I mean, it's touted with that uroselectivity, but in real life, are there any comparative studies?
Okay, so maybe you didn't pick up my sarcasm lah.
Yeah.
You know, I think all the drugs, we are clinicians. I think maybe only Josh Lee is so-called pharmacologist lah. We actually never really look at it. I tell you, many of these medications, we don't actually know how it works. We don't know how it works. I think the company probably also not very sure. And laboratory studies in the petri dish doesn't translate, on the rat muscle doesn't translate into clinical practice. It's just like, what is this? Cialis, no, this tadalafil can move uroflow. It's actually, you know, they postulate 4 or 5 mechanisms. I think the studies basically shows that it is as good, if not slightly better, than the other alpha blockers. And we all know, I think all the urologists know, alpha blockers, the endpoint is basically the same. That's my honest view lah. Although I don't have a dinner tonight, so it's okay.
Okay. All right. The other question I was going to ask is basically, let's talk about Nocturia. Is there any particular mechanism whereby this drug is better than all the other alpha blockers for Nocturia? Is this Nocturia the first choice where you would go to? Or is this 1 or 2 studies? Because I believe they're all basically the same now.
Oh, Peter, I think you got no dinner tonight already. Yeah, virtual, right? Yeah, virtual. Yeah. So let's answer the question. I think it also depends on the underlying mechanism lah. Because we like to think, you know, I mean, 5 years ago, we like to think, if you're not emptying your bladder well, we give you an alpha blocker, whatever we give you, empty the bladder better, or even double void before you go to sleep, you know, then you have less nocturia. So basically, I think it's probably that, but at the same time, we cannot ignore the studies done by a huge group of people, you know, looking at it. They probably done the study and then they go back, they see, you know. So actually, we must give them the benefit of the doubt, since we don't understand the mechanism anyway, you know. So if the study says we have done this number of patients and they have got less nocturia, and I think other companies probably not doing the studies, though I think I've seen some studies done for other alpha blockers, they also reduce nocturia. They also reduce nocturia. But I think it's only one of the factors. It's like a shining light, because patients complain about nocturia. You give them an alpha blocker. They say, why you give me alpha blocker? And then say, this study shows that it can reduce your nocturia.
You know, when they marketed tamsulosin, they always touted it as also affecting and blocking alpha-1D receptors in the bladder. Does silodosin have a similar effect to basically reduce some instability?
I think the person in this room who wrote a book on BPH is Peter Ng. So I think you answered the question.
No, I have no data from the company, so never mind.
Alpha-1, BCD1, even Chris Chappell, when he gave the lecture, they don't really know. They don't really know. I think basically, the more uroselective you are, the more you'll be targeted on the prostate and the seminal vesicles and the ejaculatory duct. So that's why for children who have got dysfunctional voiders, I tend to give them non-selective. Like we give them like Cadura, or we give them Tarajosin. I tend to give Tarajosin for dysfunctional voiders because the problem is in the bladder neck, the area, So I think that is probably we are on the right track. We think on the right track lah. So I haven't used it for children dysfunctional voiders.
Okay. There's some more questions that are coming in now. One is from Dr. Vijayan Manoran to all panelists. What is your experience with stopping alpha blocker once patient is stable on dual therapy? Is the effect on the lower tract symptoms sustained?
Okay,
Dr. Vijayan.
My answer is no lah, unfortunately. So studies and real life is different. This patient has been taking for so many years. Say, doctor, I don't want my father to take so many medicine. Can you take off one of them? I take off the alpha blocker. The patient cannot have problem passing urine. So in real life, I don't know about the rest of you, but in real life, patients on dual therapy, most of the time they are on dual therapy for life lah.
Okay, good. Any other comments from other panelists?
Dr. Praveen, Dr. Praveen. I saw a patient. Any role for alpha blocker in female voiding dysfunction? Wow.
Yes.
Female voiding dysfunction. Wow, that was a very, very tough one. Very, very tough. Send them to Dr. Who is the best in Malaysia for female voiding dysfunction? who is the Korean urologist? We're just joking now. We make it lively. I think I sent to Dr. Warren Low. I think female voiding dysfunction. Actually, I think most of us we just try lah. We just try, but it's a tough one lah. I think probably it's multifactorial lah. Multifactorial. Female voiding dysfunction. I think if another doctor, another senior urologist he will go and dilate all of them lah. Not only dilate, you cut them to 32 French, something like that. You know who lah, Dr. Vijay. So I think that's a tough one. I think we can try lah, no harm, but make sure that you don't give them a problem lah. Don't give. Of course, they have no retrograde ejaculation, but don't give them hypotension lah. Hypotension and necessary.
Okay. Right. Any other questions? If not, I've got another one. Since Clarence talked about the gold standard being the TURP, could you want to give some comments on some more recent? I mean, we get a lot of patients to tell us about Prostatic for aquablation. Can you give us some of your wisdom there? Since it's MUC, and then we've got the expert here. So can you tell us a bit about, are they useful? Any data?
I anticipated this already. So I started to give an answer in my lecture already. But I can tell you the problem is that every day somebody will send me a video, send me a link, say, "Doctor, have you heard of this? Don't you do this? It is available in Malaysia." And this usually refers to Rexium or thermotherapy or dilatation, and even tuna also they still send to me. So usually, I sometimes I oblige, but after you send me 3 or 4, I get very bad tempered. Like I said, I'm not Mr. Google, and of course we can counter lah. Basically, I think most of them, except for Rexium in the UK, which is unfortunately licensed under the NICE guidelines. So once it's their license, then they expect Malaysia to do it as well, like, especially the senior government servants. They want to fly there and do the procedure. They say, it's the day procedure, outpatient, local anesthesia, blah blah blah. I think all this we can think about it, like we can think about it, but I think a proper good TRP to me is the gold standard. You remove enough tissue in the right places, you have withstood the test of time. You can do enucleation, also very good, but of course, if it's a tougher thing to learn, you can learn it. As urologists, we can learn it, no problem. So basically, I think the TRP is still the gold standard. If it's a huge prostate, like 200 grams, then maybe I think, because if you enucleate 200 grams, you still have to modulate it. So might as well just do an open prostatectomy, So that is my basic understanding. But we're open to it. We're open to it. You have to be open to all these new ideas. Things may change. We can try it also. If they bring the thing to us, we will try. I'm sure Vijay will try. Thor will try. If they bring any thermodilatation, but of course, myself the patient, you are trying it. It's an experimental technique. Thank you, Peter.
Yeah, okay, so I've got some more questions or comments. Welcome, Prof. Fu from Singapore. KT Fu. I want to read his comments to you. Excellent presentation, Clarence. For Nocturia, we need to exclude persistent post-void residual urine and UTI before we use alpha blockers. Therefore, need to grade and stage the disease clinical BPH first, plus ultrasound. Clinical ultrasound is important. You want to answer to that?
Yeah, I hope all the young listen to exactly this. And anyway, I preempt this. I put this in my lecture already. Okay, you must do a urinalysis. You must do an ultrasound. You must stage it. You must grade it. And then you give the appropriate treatment in the background of all the rest. Nocturia, BPH is only a small fraction of Nocturia concern. It's a small fraction, but it is an important fraction.
Yep. I've got a comment from Susan. She says, use alpha blockers in PUVs and in primary bladder neck obstruction, MET. I use tauroxetine because it's easier to titrate. That's what Susan says. Any reply to that?
Yeah, and also I think following on your comment, Peter, it is not so uroselective. So it also acts on the bladder neck and the trigon. So tauroxetine is preferred as compared to the more uroselective ones. And of course, you can titrate 1 to 5 milligrams. I know it's easier to titrate. And you can cut the tablet as well because it's not one of those SRXL thing, no? Okay.
Yep. Okay. And then was another comment from Satya. I think you've already answered about other minimally invasive treatment, Rexium and all that. Right. Any other last minute questions? This has been a very interesting topic, and everybody has had their hands on BPH, all of us. Any other last minute questions before we close the session? I think we're going to be on time. Okay, if there's no other, let me take this great pleasure in thanking Clarence for his wonderful presentation and very good Q&A from everybody. Thank you, Isai, for sponsoring this session. And hope you all enjoy the rest of your conference. This is the first time we're doing it. I think it's going to be a tremendous success. Thank you.
Thank you. Bye-bye.
Bye-bye.